Dr. Dillon brought up something very important in his talk regarding the subcutaneous fast-acting octreotide with one of the E's, namely ethanol. It's extremely effective when you give 100 micrograms about 30 minutes before you go out socially in protecting from the flush that many people get when they have active carcinoid syndrome. And I thought, and that was alluded to by Leanne as well, but that puts the rubber on the road and is very effective. Same goes with exercising. If you take a short-acting sub-Q, now they have the quick pen, which is marvelous with virtually 100% absorption with the injection that 30 minutes before reaches the peak for short-acting octreotide is very effective in allowing a person with moderate activities to go longer. Isn't that right, Leanne? Yeah. Oop. I don't think.
Yeah, I think, Leanne, you might have to turn on your microphone.
Yes.
Good.
Hey, Dr. Odo, can you hear me now?
Yes, yes.
Dr. Dillon, do you have your microphone on?
Yes, I have my microphone on.
Okay, well, I'm getting out of your way then. Thank you for bearing with us as we went through this kind of technical journey, but we're back, folks.
Yeah, and I just was
Dr.
making
Odo.
a comment. Yeah, go ahead, Leanne. Go ahead. I don't think Leanne's hearing us.
Leanne,
Joe?
can you hear us?
I can hear, yes.
Yeah,
Leanne, can you hear us?
I don't think so.
Ah,
I was just commenting, Joe, on the use of the, you mentioned with the alcohol, that 30-minute injection of the short-acting and how effective that can be. And the same for people exercising, taking it about the peak time, I think, is 24 minutes for the sub-Q. And that really can be very effective for prolonging a person's ability to exercise when they have the syndrome.
Absolutely, Tom. It's a great trick which you taught me
Great.
quite some time ago.
Can you hear me?
But it really helps folks who have identified something that precipitates their symptoms.
Yeah.
If they can get in some of the octreotide, and I think now with the pen making it somewhat easier to have your octreotide with you at all times, it may make that a simpler matter.
Yes, thank you. I see if Leanne's on yet. I don't think we have Leanne yet. The other thing, Joe, that was really quite interesting was your comments on the oral preparation and the half-life or the peak hitting it. I think it was 2-point-something hours.
Just over 2 hours, right? So I don't see that as being something that will replace the
hold on 1
octreotide
second and we'll give that a shot.
for breakthrough symptoms, because it would just take too long.
Too long. No, that was very, very helpful.
Now, if people are taking octreotide, 2 or 3 times a day on a regular
Hey,
basis.
Jimmy, somebody's calling me too from New York. Hey, is this Jimmy?
Can you hear us, Leanne?
I can hear you.
Okay. All right. So turn off your mic. Turned off your mic. Okay. All right. So we're gonna try and put her through my cell phone. No, we're not. That's not working.
Y'all can hear me, and they can hear me. And you can tell me the question.
Quite distant.
I can
Yeah, okay. All right. So, Dr. Odo, I have Leanne on the phone, and for some reason she can't hear us, but we can hear her. So if you want to ask me the question, I will
Okay.
relay it to her.
Okay. Uh, uh, now, I'm just thinking as we go along, Leanne, I was commenting on your comments about the exercise and the different E's that can cause a problem. So I think we handled that one, and we have another question regarding Joe. If I could, with you on this one, was the modified uh, small invasion for cardiac valves that have come up, where they're using much more minimal invasive surgery for the valves. And I think that would be in the realm of therapy, which opens up doors for other therapies for carcinoid tumors.
Right. There have been great advances in a more minimally invasive valve procedures, and these have to be very much individualized, I think, with the which specific valve is involved. Frequently, with neuroendocrine tumors, there are both valves may be involved on the right side of the heart. So there may be technical issues which require more an open cardiac surgery rather than a minimally invasive one. But I think that this will the having the ability to do more minimally invasive surgery may get us to do more cardiac surgery, because it will be a less morbid procedure, and do it a little earlier in the course of the syndrome. Up to now, we've tended to wait until people were quite symptomatic.
Can you hear me?
Hearing you now.
I'm still saying.
Yes, it's true, and I think it's opened the door for possibilities in terms of demurring on perhaps reductive liver surgery until the valves, if they're symptomatic and functional, because we've both seen that in the clinics where the surgeon Dr. Howe would demur for a bit of time and go forward, to improve the valves and the function.
Right.
And I think you're right on that.
Yes, I can see that from a surgical point of view, especially in the liver, it must be it must increase the difficulty and morbidity when you're operating on somebody who has poor valves. So it would be better to take care of the valve first in that situation, and that would allow the surgeon to do a better job with clearance of the liver, which is such an important part.
Yes, thank you.
Okay, Dr. Tom, I think we have a circuitous route to Leanne. If you have a question.
I can hear you, Dr. Odo.
Yes. Okay.
Dr.
Good.
Odo.
Good. Yes.
Oh, good.
I can hear you too, Leanne. If you have a comment there. Leanne, I don't think we're connecting again. Is our participants have any questions out there that they wish to ask Dr. Dillon or Dr. Barnes.
Okay, okay.
I think we're a little technical right now.
Yeah, yeah. Well, I have Leanne on the phone. So if you have something for her, Dr. Odorizio, I will relay it. And it sounds like you can hear her, but she can't hear us.
Okay.
I do see one question in the question board.
Okay, go ahead, Joe.
It says, do nets cause a problem with interstitial fluid buildup, and what kind of a doctor can help with this? So, interesting question. So, nets could cause a problem with fluid retention. I think there are many possible mechanisms for this. One, the neuroendocrine tumor may be a large neuroendocrine tumor in the pelvis might be interfering with the lymphatics coming back from the legs, or the veins coming back from the legs. Neuroendocrine tumor within the liver might be interfering with the blood flow back into the liver and cause fluid buildup in the abdominal cavity, which is what we call ascites. I think that in both cases, the focus needs to be on trying to remove the bulk of the tumor. Again, getting back to Dr. Liu's point, surgical procedures would have to be considered highly in that issue. Milder forms might just respond to a diuretic medication, for example.
Well, and I would also, Joe, I think that's a superb differential. I think we've seen it with some radiation post PRT, interstitial kind of edema, or at least we've suspected it in some of those, very advanced mesenteric involvement, where you get that kind of fluid, that irritation temporarily. I think that would qualify too.
Right.
And in that regard, we've kind of thought about and do in fact use after PRT, we'll give perhaps steroids for a certain number of days to try and minimize that. What we thought we were seeing was some acute bowels or partial bowel obstructions after PRT with more serious bowel involvement, and that seems to work. We don't have a large series.
Right. So, Tom, I'm seeing some questions come in the question list. Maybe I could pull some of these and just
yeah, if you could do that, I'd appreciate it, Joe, because I don't see them.
All right. So this one for me: if a primary lung tumor was removed and now is back, would you have it removed again? Well, as Dr. Liu mentioned this morning, each patient's history has to be really considered very carefully, and yes, there would be a possibility of going back for a second surgery, but it really depends on where it is and what structures are involved, and so surgery would be a consideration, but really have to go and see a neuroendocrine tumor specialist who might help you work through that.
Yes.
If you have a syndrome, does that mean that you have a microscopic tumor? Perhaps this is a question for me as well. So people with macroscopic tumor, or tumor that is easily visible, can have syndromes, but we certainly see many people who have who have syndrome before the tumor is found, and this is you've heard this many times of people who've waited years for their diagnosis. They've been flushing for a number of years, or they've had diarrhea for a number of years. They've had irritable bowel diagnosed, etc., etc. So unfortunately, all of the symptoms of neuroendocrine tumor can be mimicked by things that are much more common, and will be so that when a person comes with diarrhea, the first thing that the first and second and third and fifth and 15th thing that physicians will think about is other causes of diarrhea, because they're more common than neuroendocrine.
Yes.
So it is, as to the question, if you have symptoms, could it be a microscopic tumor? Yes, it could be a microscopic tumor that hasn't been found, but it could be some of these other more common things as well.
Yeah. Yes. And in that regard, Joe, maybe biomarkers could be helpful. I'm not sure how you feel about that, but that especially in a setting of known neuroendocrine tumors, that's one thing. But using biomarkers sometimes to help discriminate with symptoms, that's not really been very explored, or at least in a prospective way.
Right.
But when you know the situation, I think they can be helpful.
Right.
Go ahead.
Dr. Odoricio, I think we have time for one more question. Sorry for the technical difficulties, but perhaps I can invite you, Leanne, and Dr. Dillon to join our podcast one time, sometime soon, and answer these questions.
Sounds like a good plan, because there are a lot of questions that I've seen come, and now I can't find them anymore. I'm sure they're.
Well, you know what? We're lucky that we can use this platform and reach people, but the electricity does go the way it wants. So one more question, and then perhaps Dr. Odoricio will stay on, and we can get Julie on to talk about her journey.
Thank you, and I'll be more than happy. As we get better at this, I'll get better too. So
no, you're coming in. It goes for all of us, Leanne. So, you see one there, Joe, or no?
I see one here. So from a nutritional standpoint, how do you lower the risks of recurrence for someone who has no evidence of disease after surgery? So recurrence and nutritional issues in recurrence in somebody who's got no evidence of tumor now.
I don't think that we have any knowledge that nutrition is going to prevent a reoccurrence, do we, Dr. Odoricio? That I know that being able to improve your immune system and have a good, healthy diet can help you boost your own immune system. And that's what we're talking more about in this genomics of nutrition, where we just try to get you to use more nutritional dense foods. But as far as reducing incidence of tumors themselves, I know we have some early research that you had spoke about maybe earlier. But to my knowledge, and Dr. Odoricio or Dr. Muir, do you have anything else there?
Yeah.
Go ahead, Joe.
No, I don't think there's anything known about, unfortunately, there's nothing known about, or there's not much known about the what causes these tumors in the first place. So what causes them to return is also an unknown. It's an area of, again, active research in many places. So we hope we'll know something more in the future about what genetic changes occur in tumors and what might initiate those genetic changes. But unfortunately, the answer is we don't. The answer is keeping a healthy diet and then keeping yourself otherwise healthy is the best thing for your health going on.
Yeah, and as Leanne spoke earlier, we're in a process a lot of times of prevention, especially with the chronic. Our patients are, thank God, are having a longer quality of life, and so the fibrotic process, especially with the carcinoid tumors and all of the vasoactive substances you measure, must be in some way imparting, the process or worsening the process. And I think prevention in nutritional prevention.
I agree. I think that the best job we can do at keeping an anti-inflammatory effect, and some of our foods definitely can increase the inflammatory effect of our food. We know that with sugars and processed foods. So the less we use these inflammatory, and the more that we use foods that decrease these good nutrients that we find in antioxidants as well, are probably our best defense against what we have, as far as, especially because this is chronic, this is a long time, and so many times we'll see problems with many other comorbidities along the way with diabetes and hypertension. So do eat healthy, and we'll try to get more information and try to teach more on how to make foods easier to digest, easier to absorb, and do that as our goal. Thank you again for having me today.
Yes. Thank you to everyone, to our presenters, and to Dr. O'Dorisio.